Yeah, so I don't have here in the paper, but originally in the session we would have Dr. John Kanellopoulos presenting, right? Presenting ray tracing LASIK Wavelight Plus versus MIO for myopia correction, a randomized prospective contralateral eye study. It's not in the paper, but it was in the original session, right? So
Okay. So I do it or I do not do
you
it?
should do it, yeah.
Okay. All right.
Yes, we're excited.
Yeah,
All right.
yeah, we're looking forward
Good morning
to hear.
or good afternoon, I should say, Santiago and
Yeah, LASIK versus smile. Didn't
looking
take-
at
didn't take
the
long.
number of people in the room, I'm understanding why refractive surgery has such a downturn. So this may be a talk that does not interest many, but it certainly has interested us. I do have financial disclosures to make about this talk. I consult both for Alcon and Zeiss, and this is comparing the two technologies, two leading technologies for these companies, head to head, and it was funded by Alcon. And we've done this work before. We have compared SMILE back when we used the VisuMax 500 femto by Zeiss and topography guided LASIK using the refractive suite by Alcon. And obviously there's advantages and disadvantages in both procedures, and having done thousands of procedures both in the US and in Europe, and also, and this is relevant to the talk we heard before, being bombarded every day with commercials and biased material that this procedure will make your life better. Smile Pro is the way to go. Ray tracing is the way to go. A seasoned clinician always adheres to what works best for their patients. And this is what we try to do here. We try to compare in our patient population, one eye doing ray tracing LASIK with the Wavelight platform, and the other eye Smile Pro, which was a new kid on the block for us, as we had acquired recently when we started this study, the VisuMax 800 femtosecond laser. So I'm not going to go into detail about the advantage and disadvantage of each procedure. I think I see a lot of seasoned refractive surgeons here. This is what I've come to call older, now that I'm older myself. What we did in actuality is treated, randomized, one eye LASIK, one eye Smile Pro, but we cheated on the Smile Pro eyes. We used the ray tracing generated refraction. And I think this is a key component and maybe the most important thing in this talk, because now we have technology, and I think this, along with AI, may help a lot in the main thing behind success in refractive surgery, which is the actual refraction. Because we know we have technology now and surgical skill to achieve almost perfection, but the parameter that's still lagging is what is the actual refraction. And since we're dealing with younger patients, and I don't want to turn this talk into how accommodation affects refraction, but I think this is the key thing that we should be talking in refractive surgery today, accommodation, something that I don't have anymore. But anyway, so we looked at 60 patients, and it appeared that even this large group in a contralateral eye study for these two techniques was not enough. We should have, in retrospect, have gone with 120 patients, and this underlines how similar these two procedures are. There were some fine differences in fine details. Let me show you a pre-op to go more in clinical hands. These are two eyes of the same patient, and these are the contrastivity pre-op. These are the waveform maps generated by the sitemap device. This is a proprietary device for Alcon. It was recently FDA approved in the US, I think several months ago. We have been using it in Europe since 2019. So it's able to measure actual length, wavefront, and Pentacam HR, and use these data to feed a ray tracing protocol that through a three-dimensional virtual eye of each eye that it evaluates, and this is a really switch from paradigm. We're not working with a Goldstrand eye to calculate treatment now. It calculates lower aberrations, so myopia and astigmatism, and higher aberrations as well. So we use the refraction for the SMILE eyes. All our other parameters were the same, and these are the same eyes of that same patient. Right eye on the left treated with ray tracing, left eye on the right, and this always confuses patients, but fortunately not us eye surgeons treated with Smile Pro. And you can see that the differences are minuscule. Both eyes achieved excellent postoperative emetropia. Contrast sensitivity is almost comparable, maybe a little bit better for ray tracing LASIK in the higher cycles per degree. The epithelial maps, this was noted previously, very good point, are slightly different, and we have published on how SMILE and LASIK do affect differently epithelial remodeling all the way 3 years out of comparative control eye procedures. And looking at the data more carefully, we found that the LASIK eyes with ray tracing had significantly more gain of one line of vision than the Smile Pro eyes. Although 100% of both groups achieved 20/20 visual acuity, so I know that in today's refractive surgery, 20/20 is not our goal. Our goal is to take advantage of the technology that we have and also improve the visual optics. And we've reported this consistently in the past by using TMR and topography-guided treatments. And I think ray tracing came to really underline all that work. So looking into a 3 months uncorrected visual acuity of 2015, again, the ray tracing eyes here were far superior than the SMILE eyes, and also better in contrast sensitivity. So in conclusion, these data are almost too good to be true, but they do show that using objective measurements, if I can use this term, with ray tracing and using these numbers to perform femtosecond LASIK and the same refraction numbers but no higher aberrations to perform SMILE Pro gave excellent outcomes in control eye study. Now, the ray tracing eyes appear to be better in lines of vision gained and induction of higher aberrations, but this is kind of expected since SMILE Pro has yet to include higher aberration correction into the ablation and other forms of customization. And that's all I had for you today. Thanks.
Great. So, John, I have a question. I think one of the points that have been raised when people are talking about ray tracing LASIK is about the time is a little bit time consuming to acquire let's say, good data to use it preoperatively. Also, some surgeons say that maybe it would be better to have the patient dilated, so it would be better to bring the patient one day before or in a different day to acquire the data and then do the surgery in another day. What's your opinion about that?
You make a very good point, Santiago. I'm convinced, and I argued this in the beginning, that ray tracing measurements should be done in a cyclopleged eye. It has not been the case in the beginning, but I think most surgeons using ray tracing currently are using the, not cycloplegic, but dilated refraction with tropicamide used a half hour before. Because again, it does take away the accommodative effect of these measurements. But despite the fact that it is time consuming to spend 10, 15 minutes with a patient and make these measurements, for me in my clinical experience, and I've had the opportunity of working with excellent optometrists, it does create a very thick safety net when you're measuring these patients. And the key thing here is astigmatism. And I pose the question to all the experienced surgeons here, why is it that we're treating less astigmatism in refractive surgery that the cornea has? And my answer is that we have been doing this wrong. We should be treating all of the total cornea astigmatism when we do refractive surgery. And ray tracing is helping going towards that direction. If, as you will very well mention, cycloplege the eye, you take away accommodation. If you don't take away accommodation, the measurements will consistently show less astigmatism than your total cornea numbers. And I think in today's era, and considering what other investigators and we have published, this is not the right way to go.
Great.
We just actually just started our ray tracing work, and I've never seen a time when we were checking down at 2015 and 2010, unless we were in a clinical trial, like we are now with ray tracing. So it's not very often that I feel like there's a paradigm shift, and ray tracing helped the implant world a while ago. It's now helping the LASIK world. I can't wait till it helps the SMILE world. But this idea of, more than one refraction, and understanding the cornea centrally and peripherally, and being able to use that data has been absolutely unbelievable. And so I'm a big believer. And did you study centration?
Yes, we're going to spin off several projects as we did with our original topography guided and SMILE study into looking at centration, tissue removed. But I do stand behind what you mentioned, which is very important. Even the refraction is a tremendous tool to use in SMILE Pro eyes. And I know these numbers are extraordinary. Actually, this paper got rejected by the JRS because the commentary was that these data are too good to be true, but there are objective data. And I think that it makes sense just on the diagnostic side to explore this technology, because it does make a difference between subjective refraction and all the gold standards that we've been using so far.
I think you should resubmit it. I think what's happening, though, is you're ahead of a lot of the world in your understanding of ray tracing, because, when we did the clinical trial in the U.S., we had challenges in understanding how best to use the sitemap device. And now, post-approval, we've taken those learnings, from the trials and from people like you, and it's a beautiful addition to refractive surgery. And I think, everybody doing LASIK needs to be incorporating ray tracing.
Well, I don't want to take much of the time, but the more you learn about customization of treatments, the more you feel they're mandatory when you're doing refractive surgery. Many people still confuse ray tracing with waveform guided. It is not waveform guided. The two key elements are the fact that if you're looking at a non-accommodating eye, you have total refraction of that eye. That's number one. Number two, you're recentering the visual axis not to the center of the cornea, but to the actual visual axis of the patient. And that's where all the refraction has been set, and that's where the patient's function. And last, which is not really discussed much, it does correct tilt as well. Because we all perceive that the human eye, the way it views and the way we view it when we measure it, is untilted. And the tilt is regards to how the cornea parallels to the lens. These two lenses, these two lenticular systems in the eye are not always parallel. So it has the ability to correct that as well. So if you put all these parameters in mind, it is opening the door for you to get these high visual function results.
Well, John, we could listen to you all day. I mean, you're just a wealth of wisdom. And plus, next year, submit that talk on accommodation. I want to learn your philosophy. So thank you very much.
Thank you. Thank you. Thanks for having me.